Welcome back, everyone. My name is Mary Marsh, and I'll be your speaker for today. As previously mentioned, I'm a student at Athabasca University completing my Master's of Health Studies. Today's rebuttal is for assignment 2 of my Trends and Issues course. I'll be responding to Catherine's affirmative stance that all drugs and substance use for personal use must be decriminalized. Catherine's first argument is the financial impacts of criminalization. She begins by sharing the estimated cost of illegal substance use on the healthcare system in 2017 was $1 billion. She then shares how criminalization of substance use can cause delays, further incurring costs on the healthcare system. Lastly, she points to the financial costs of the criminal justice system and how it exceeds that of the healthcare system. In 2017, an excess of $6 billion was spent on incarcerating individuals for illicit substance use. In reviewing Catherine's argument, I observed that the vast majority of her argument was based on a position statement published in 2023 by the Canadian Psychological Association. In reviewing the article, I was able to locate where they spoke of the cost of criminalization and the costs placed on the healthcare system and how it costs $1 billion to treat those using opioids and cocaine. Interestingly, they linked this cost with overdoses, sharing how between January 2016 and September 2020, there were 23,240 opioid-related poisonings and 10,518 stimulant-related poisoning hospitalizations in Canada. If you can recall from my presentation, decriminalization has not been shown to reduce drug poisoning events and deaths. Data from BC Emergency Services shows that overdose and poisoning calls in BC increased by 25% following decriminalization. This proves how decriminalization would have no impact on the healthcare system aside from the need to increase funding and programming to meet the needs of the communities. Another point I'd like to make is if you look at the data, you would see that alcohol, which is legal, is costing Canadians $19.7 billion in comparison to opioids at $7.1 billion. Another interesting statistic is how in 2020, tobacco was the leading cause of substance-related deaths, with 43,366 deaths in 2020, followed by alcohol at 17,098 and opioids at 6,491 deaths. This shows that funding needs to be placed in other areas. Catherine's second argument is the impacts of criminalization on racialized and/or impoverished community members. She shares how Black, Indigenous, and people of color are charged and arrested for drug possession at higher rates than white Canadians, despite their similar usage habits. Furthermore, she shares how individuals previously incarcerated are at higher risk of future incarcerations, which then lead to housing and job insecurity. Lastly, she ties this into British Columbia's pilot project, which has been shown to prove that fewer arrests and interactions with police have resulted since the implementation of decriminalization. Catherine is correct in saying that the harms associated with criminalization are disproportionately experienced by those who are most marginalized in our society. With that being said, Canada's substance use services do not effectively address underlying structural factors such as poverty, racism, homelessness, and colonization, which are known to increase risk of drug-related offenses. There's a larger issue that needs to be addressed utilizing a public health approach. It is not merely a matter of criminalization versus decriminalization. Utilizing a public health approach, we would recognize and collaborate with people with lived experience and those actively using substances. We would support the underlying determinants of health and address health inequalities. A critical component to addressing substance use is to look at the societal determinants of health, including the provisions of housing, food security, mental health and wellness, community supports, access to tradition and culture, and employment. It is collaborative and comprehensive and ensures a continuum of programs and services are available to meet people where they're at. The criminal justice system in Canada has already taken steps to address systemic racism through Bill C-5, which allows police and prosecutors to consider other measures for simple possession of drugs, such as diversion to addiction treatment programs, rather than laying charge or prosecuting individuals for simple possession of an illegal drug. It restores the ability of a judge to impose appropriate sentences that respond to the facts of the case before them, including the individual's experience with systemic racism and the risk they pose to public safety. This moves away from the one-size-fits-all approach, which has not deterred crime, but has resulted in unfair outcomes and a less effective criminal justice system. As previously mentioned, Bill 110 was passed in Oregon. One of the goals was to reduce racial inequalities in Oregon's criminal legal system, given the stark racial disparities for possession of controlled substances, arrests, and convictions. Oregon's failure demonstrates how decriminalization did not reduce racial inequalities within the criminal justice system. The majority of people who use drugs, 74%, reported criminal legal system involvement in Oregon following decriminalization. Shockingly, people who were unhoused had 6.8 more law enforcement stops than housed people who use substances. This demonstrates how decriminalization does not address marginalization. Catherine's third argument is that decriminalization is part of a robust public health response. She argues that decriminalization is just one part of a robust public health response to the toxic drug crisis, and that decriminalization alone is not sufficient in addressing the harms that are caused by the toxic drug crisis. She places an emphasis on BC's decriminalization project that aims to destigmatize people who use drugs, and how their project also places an emphasis on complementary service investments such as additional housing and health supports. Catherine's argument states how BC's decriminalization project destigmatizes people who use drugs and supports complementary service investments such as additional housing and health supports. If you recall, evidence shows how experiences with stigma persisted post-decriminalization in British Columbia. 51% of harm reduction site users reported hesitancy in accessing services. This is why effective drug policy implementation and sustainability relies on knowledge and support among stakeholders. Unfortunately, Canada's substance use service systems are highly fragmented and often isolated from mainstream health and social care. While decriminalization aims to improve access to health services and pathways, this statement assumes that a treatment infrastructure exists and is adequately funded within the province. Of note, in Canada, only half of the recommended amount of funding goes to mental health. Furthermore, BC reports a higher distribution of psychiatrists, 14.8 per 100,000 compared to the Canadian average of 13.1. However, the data from other indicators in this report suggests that there may be other barriers to receiving mental health and substance use health care. The reported rate of unmet and partially met needs for mental health and substance use care is higher in BC than the Canadian average. In conclusion, I stand by my position that all drugs and substances for personal use must not be decriminalized. Rather, a robust public health model should be developed focusing on prevention, treatment, recovery, supports, and addressing the broader socioeconomic conditions affecting our communities. I would like to thank you for listening to my presentation and rebuttal, and I look forward to the conversations ahead.